Medurstand, Understanding Medicine.
I am Professor Aziz-ur-Rehman, and we are discussing various radiological abnormalities, and I have already discussed a normal X-ray chest, and then we had a full lecture on pleural effusions, and then we also had a lecture on COPD and pneumothorax. So this is the next in the series, and today we're going to cover pneumonias, collapse, and cavities in the lungs. Now, again, I would say that this is actually from the internist point of view. Obviously, you can get more details from a radiologist, but what an internist need to know, the common conditions and the common presentations, I think every physician need to know. So I'm going to be focusing on those aspects. I hope that is useful for you. So let's start. To understand the consolidation and collapse, we need to understand the normal anatomy of the heart, normal anatomy of the lungs. You know, we have two lungs. They consist of lobes. On the right side, this is the one in the green is upper lobe, and in the orange is the middle lobe, and the red one is the lower lobe as marked here. Now these lobes are separated from each other by fissure. This is the transverse fissure. So lobe above transverse fissure is upper lobe, and below that is the middle lobe. And then this is the oblique fissure, and the oblique fissure separates middle lobe from the lower lobe. Now from the front they look separate, but when you see the X-ray, there is actually a lot of overlap. All these three lobes overlap with each other. So that if you want to really know where that opacity is it in the anterior part, middle part, or the posterior part, or which particular lobe, then you would probably need a lateral film also. Because, for example, opacity here would probably look the same whether it is in the lower part of the upper lobe or upper part of the lower lobe. On the left side, we have one big upper lobe, and then there's a lower lobe. There is no middle lobe. Middle lobe is actually part of the upper lobe. So there is no transverse fissure on the left side. I believe in some cases there may be one, but mostly there are only two lobes. Again, this is oblique fissure, and there will be a lot of overlap. For example, opacity here. From front, you are looking at only the upper lobe, but actually there is significant part of the lower lobe also, because they overlap with each other if you look at them from the lateral side. So this is the basic anatomy, and this is the trachea, carina, and the main airways, the main bronchi. So after learning about the basic anatomical details of the normal lung, let's see how these abnormalities, the consolidations or lobar pneumonia affects these lobes. Now I'm going to show you some X-rays, and then we'll describe them. Of course, this X-ray chest shows some abnormality, and it is quite obvious that this area is not normal. If you compare this part with corresponding left side, you can clearly say that this part is abnormal. There is a homogeneous opacity, with uniform opacity, and this opacity is in the upper right lobe, and it is demarcated by a very sharp lower margin, and any sharp margin in the X-ray is most likely to be due to fissure of the pleura. So this is the pleura. Now if you recall your anatomy of normal lung, this is transverse fissure. So anything above transverse fissure has to be upper lobe. So this is consolidation or pneumonia of right upper lobe. Alright, so this is simple, right upper lobe. Another point I would like to emphasize is that pneumonias, generally speaking, do not take up more space. Only the normal alveolar air is replaced by exudate. So there is no increase in volume. There is no loss of volume. so the neighboring structures, they remain in their normal position. This is trachea, so this is again in its normal position. This transverse fissure is again straight, it has not been pulled toward the opacity, so this is very likely to be consolidation, pneumonia. Another X-ray, same abnormality, but in this case it is more dense. This is more uniform, affecting the entire upper lobe, and you see the transverse fissure. The lower border is again sharp, but it is not straight. Perhaps it has been pulled by this consolidation. In some cases there may be some volume loss, or there may be some underlying atelectasis, and that might pull the neighboring structure toward the opacity. So I think that is the reason this transverse fissure has become oblique and has also become somewhat concave toward the opacity. So this is consolidation. This is fully consolidated lung. Consolidation or pneumonia, it actually passes through various stages. Initially it develops and then becomes fully consolidated, then the process of resolution starts. In any X-ray you may see an opacity which is not very homogeneous. Unlike this one, this is very homogeneous, so this is fully consolidated lung. But in some cases you may not see the opacity which is that homogeneous. In other words, it may be heterogeneous. Trachea is in its normal position, and you can, I think, see this black column. This is due to right main bronchus. If you have a diffuse opacity and you can identify a black column which correspond to the bronchus, this is called air bronchogram. Air bronchogram is actually hallmark of consolidation or pneumonia. And the rest of the lungs are okay. You can see costophrenic angle, cardiophrenic angle. On the left side, the entire left side is normal. There's a big gastric bubble for some reason, but this of course is not related to this pneumonia, although I just remember that in some cases of pneumonia there may be acute dilatation of stomach. Maybe this patient has got that complication. So this is another case of right upper lobe pneumonia or consolidation. This one is slightly different. I'm sure you have figured it out. There is an opacity, but this time it is not on the upper part, it's in the left here. Now, instead of having a lower sharp margin, this opacity has got very sharp upper border. This is again transverse fissure, and the lobe below transverse fissure is middle lobe. So this consolidation is in the right middle lobe. It is perhaps just started developing. It is not that dense and it is not that homogeneous also. This part is getting consolidated, and the lower border is not marked because it hasn't yet, the consolidation process hasn't yet reached the oblique fissure. Once it reaches there, then the lower border will be like this. Of course, after diagnosis, treatment is offered, and this patient might not develop full consolidation of the lobe. But if it is not treated, then it will progress to involve the whole right middle lobe. So this is simple right middle lobe pneumonia which is developing. This X-ray again shows very similar opacity. The upper border is very sharp. This one is bigger than the previous one, thicker and denser than the more dense than the previous one. So this is perhaps more developed pneumonia. Lower border is also marked here. This is not exactly oblique fissure, but oblique fissure is somewhere here. This is the right middle lobe consolidation again. By the way, right middle lobe is more prone to get consolidated because the right main bronchus goes straight to the right middle lobe. So anybody who aspirates something is more likely to go to the right middle lobe. So that's why right middle lobe pneumonias are common compared to other lobes. Again, an opacity. although this time opacity is in the lower part, so it's very hard actually. It is very hard to tell, is this the middle lobe or is this the upper part of the lower lobe. The only way to be sure would be to go for a right lateral film. But there's a principle called Sillet sign. In this, if this was in the anterior part, indicating the lower lobe, if it is in the lower lobe, then this part of the lung would be in contact with the heart. So in that case, if this part of the lung is consolidated, you should not be able to appreciate this right cardiac border that well. So this is called Sillet sign. This indicates that this opacity is perhaps in the not in the lower lobe. Maybe another X-ray will show. So I think again middle lobe. Now this is how we can be sure. This is the opacity. On this opacity, this is not exactly corresponding to any particular lobe because it is still expanding. It hasn't yet involved the whole lobe, at least from this angle. It appears to be in the middle lobe. Whether it is actually a middle lobe or the lower part of the upper lobe or upper part of the lower lobe, you cannot be 100% sure unless you see the lateral film. So this is the lateral film. Now this sharp line is made by the oblique fissure. This is sharp line made by the oblique fissure. This sharp line is made by the transverse fissure. So this consolidated part, which is between two fissures, transverse fissure and the oblique fissure, has to be middle lobe. So it wasn't very obvious here, but here it is very obvious. It is right middle lobe pneumonia. These are two diaphragms. The one on the right side will be higher and will be seen more clearly. So this one is the right hemidiaphragm and this one is the left hemidiaphragm. Also you can identify the gastric bubble here, which is present here also. So this is relatively easy. Right middle lobe consolidation or pneumonia, particularly easy because we have the right lateral film. When it comes to treatment, it might not make the difference, but in some cases it is important to know which lobe is consolidated, because sometimes there may be an underlying condition which might require attention and treatment. So let's proceed to the next one now. Again, there is a consolidation here. It would be hard to tell if it is in the lower lobe or the middle lobe. But compared to the previous one, if you see the border here, right cardiac border and the consolidation, the opacity, they cannot be differentiated from each other. Now, if we see the lateral film, Sillet sign says that if consolidation is in actual physical contact with the heart, then you will not be able to differentiate two structures separately from each other, right? You don't appreciate right cardiac border here because this consolidation is in actual contact with the heart, and that is shown here. This is the oblique fissure and this is the consolidated part. So since heart is in the anterior part, this opacity has to be in the anterior part to be in contact with the it has to be in the anterior part of the lungs to be in contact with the heart. So that is confirmed here. It is actually the middle lobe indicated by the Sillet sign. I'm not sure if I made my point clear. Let me repeat. The Sillet sign says if the consolidated part is in actual physical contact with the heart, then you will not be able to appreciate the right cardiac border very clearly because this opacity is in actual physical contact. So if that is true, since heart is in the anterior part of the chest, this consolidated part also has to be anterior part. That is shown here. It is here. So this is the oblique fissure. This is the consolidated part. Had this consolidation been here, then you would be able to appreciate this right cardiac border. Best way to localize consolidated part is perhaps the lateral film, but from ciliate sign you can make a reasonable guess. From this you could guess that this consolidation is in the interior part of the lung. That is confirmed here. Again, I will highlight ciliate sign. This is the opacity. From here, there could be the lower part of the upper lobe or upper part or the middle part of the lower lobe. So this is actually an overlapping area. On the PA film, you can't tell. But in this opacity, you can clearly differentiate left cardiac border. That means that this opacity is perhaps not in actual physical contact with the heart. In other words, this opacity may be present in the posterior part of the lung if we see the lateral film. Now, this is actually true. You see, this is the opacity. In the previous example, the opacity was here. That is why it was not demarcated from the heart. But this opacity in the PA film looks the same, but in the lateral film we know that this is in the posterior part because the posterior part of the lung is consolidated. The lower part of the inferior, the lower lobe is consolidated. So this is lower lobe pneumonia as indicated by ciliate sign. This is bilateral pneumonia. This is maybe somebody very sick, somebody immunocompromised, and these days we are seeing patients with COVID with bilateral pneumonias. This could very well be a case of COVID, but there is bilateral pneumonia much more marked on the left side as compared to left. Similar or somewhat similar appearance may be seen in pulmonary edema, but in that case you would expect heart size to be slightly bigger, and you would also expect these infiltrates to be typical butterfly. I don't see that pattern here, so this is, I think, in my opinion, bilateral pneumonias. Aspiration pneumonias, of course, we always relate any imaging test with a clinical condition. So if this patient is bedridden, has got high fever, then of course it would very simply correlate with that bilateral pneumonia. This is another X-ray, very extensive infiltration on both sides. This is definitely consolidation, very typical consolidation, not corresponding to any particular lobe. Here there are multiple consolidations or one big non-homogeneous consolidation, bilateral pneumonias. Other possibilities can also be considered, but I think, in my opinion, I would read this X-ray as bilateral pneumonia, particularly if the patient is febrile. This is again similar, but this X-ray I'm not exactly sure. It could very well be bilateral extensive pneumonias, but since we do not see costophrenic angles, cardiophrenic angles, diaphragm, so there is perhaps some pleural effusion also. It is not simple pleural effusion because this part is not typical of pleural effusion. Pleural effusion, simple pleural effusion would cause very homogeneous opacities with curvilinear borders. So this part is, I think, consolidation. I believe there are bilateral pleural effusions also. This can happen whenever there is pneumonia. There may be some pleural effusion also. I believe a little bit of effusion is always there, but on X-ray, in some cases, you can see fairly big effusions also. We call it parapneumonic effusions. We have been discussing X-rays, and this module is about X-rays, but one test which is a sophisticated form of X-ray is CT scan. This opacity is not very sure. There is opacity, of course there is an opacity, but its outline is not very clear. But if you see the CT scan, this is a cross-sectional image. The opacity is very clear, and you can say that this is consolidation. This part is fully consolidated. This part is either developing consolidation or is under the stage of resolution. So this type of condition is very typical of pneumonias. Now, since we have seen X-rays, of upper lobe pneumonia, middle lobe pneumonia, lower lobe pneumonias. We have also seen lateral films. Now, let's sum up the radiological signs of pneumonias. Uniform or heterogeneous opacity corresponding to a lobe or a part of lobe. Uniform if it is fully consolidated. If the pneumonia is still developing or pneumonia is already in the stage of resolution, then opacity may not be very uniform. So it may be heterogeneous. And if it is already involved the entire lobe, then it will correspond to a lobe, whichever lobe, upper lobe, middle lobe, lower lobe. But when it is developing, it may be just part of lobe, so you may not be able to see the sharp borders caused by transverse fissure or oblique fissure. But when pneumonia is fully developed, then you can see a particular lobe outline. If not full lobe, at least one margin, like upper or lower margin. This sharp margin caused by fissure is very characteristic of consolidation. No significant shift of neighboring structures with some exception. The exceptions are if there is pneumonia along with parapneumonic effusion, then there could be shift of midline structure. Of course, the midline structure would be pushed to the opposite side. When there is pneumonia with a lot of exudation, like we see in Klebsiella pneumonia, then there could be a push of structure to the opposite side. When there is pneumonia with atelectasis, that can also happen. Suppose there is underlying malignancy, that could cause bronchial obstruction and it may lead to collapse as well as consolidation. So that could also lead to loss of volume and the structure may be pulled toward the opacity. But the typical simple consolidation would not shift the structure to the other side or will not pull it toward its own side, because in pneumonia simply alveolar air is replaced by exudate. There is no addition of any other space occupying region. Air bronchogram is also very characteristic of pneumonia. If you see a uniform opacity and in the middle of it you see a black column corresponding to a bronchus, that is called air bronchogram. Bronchogram means image of bronchus, and air because this image is made by the presence of air. So that is very characteristic of pneumonia. But it's not seen in everyone. Bronchopneumonias, I've shown you some pictures, bilateral confluent shadows. There are multiple actually fluffy opacities overlapping with each others. So the overall this bilateral confluent shadows. Bronchopneumonia, patient is likely to be very sick. After pneumonias, the second thing we would like to cover today is collapse. Now, why I want to discuss collapse with pneumonias? Because collapse also affects specific lobes and it also produces similar homogeneous opacities. But there's a basic difference. In consolidation, I emphasize again and again that there's no loss of volume, there's no gain of volume. So the neighboring structures, they remain in their normal position. But in primary atelectasis, primary collapse is a condition where there is bronchial obstruction and that leads to absorption of air distally and lung collapse. So in that case, of course, there will be loss of volume, the lung volume will reduce. Now this is one example. There is one big opacity which looks very uniform and which looks very much similar to pneumonia, though it does not correspond to one lobe. It perhaps has affected the entire left lung, but it has pulled the structure toward its own side. Now see this trachea, and this is the carina and main trachea and the left main bronchus, both are pulled toward the opacity. If you can see the diaphragm, this is the right diaphragm. The left diaphragm should be somewhere here, but please appreciate that the left diaphragm is also pulled upward. This is perhaps the location of left hemidiaphragm. This is a gas in the colon, in the stomach, and this is left hemidiaphragm. So left hemidiaphragm is pulled upward, trachea is pulled toward the opacity, and look at the heart. You don't actually see the heart. Heart is perhaps also hidden within this opacity, and you don't see heart here. See, normally heart should be seen here, so it is also pulled toward the opacity, so that is also part of this opacity. All these things indicate that there is some lesion which is causing this opacity, but that is pulling everything towards its own self, and that is collapse. And you can see the right lung is also actually prolapsing into the left hemithorax. This black column is air, and this is actually part of right lung, which is prolapsing into the left hemithorax. So this is very obvious. There are two conditions which can lead to loss of volume. One is collapse, the other is fibrosis. Fibrosis has different pattern. Fibrosis would have more non-uniform reticular nodular pattern. This one looks like collapse. So I think some main bronchus problem. Perhaps this bronchus is blocked here. You see, if you can trace the bronchus, suddenly it stops here. Probably there is some foreign body, some malignancy, which has caused complete occlusion of complete blockade of left main bronchus, resulting in left lung collapse. Collapse is perhaps very difficult diagnosis. This one is very obvious, but suppose there is right middle lobe collapse and right upper lobe collapse. They are relatively difficult diagnosis. You need to have a very high index of suspicion to pick up those abnormalities. I will not be going into those details because, as I said earlier, I am focusing on internal medicine, and I would like to stay within the scope of internal medicine. This is another opacity. The first look might suggest this is pneumonia, but see that this is the fissure. At the lower border, if this is the upper lobe, the lower border should be like this. It should be straight like this, because that is how this normal transverse fissure is. But in this case, the entire transverse fissure has been pulled upward, and there is concavity. So that indicates whatever this opacity is, it is actually, it is most probably collapsed lung, because it is pulling structure towards its own side. Trachea also, if you see, trachea is also pulled maybe a bit onto this opacity. This also looks like a collapse. So since I've shown you two x-rays of collapse, now let's discuss their causes and the features. Causes of primary lung collapse. Now I say primary lung collapse because there is another type of collapse. Suppose there is pneumothorax. As a result of pneumothorax, lung will collapse. In pleural effusion also lung will collapse to provide some space for the fluid to accumulate. But there are different types of collapses. When I say primary lung collapse, that means the bronchus is obstruction, bronchus is blocked, and the distal air is absorbed, and there is collapse of the lung or atelectasis. It is caused by maybe carcinoma bronchus, maybe a foreign body in elderly or in very young children, common thing. Mucus plug, those patients who are very sick and asthmatic patient, they may not be able to expectorate, and mucus plug can lead to collapse, and presence of blood. Somebody having hemoptysis can also have collapse. Now features: homogeneous opacity of variable densities, sharp pleural border, and both the images I showed you, they had sharp pleural borders. There is effect of volume loss and pull of midline and neighboring structures, as was shown in the two images I showed you. So these are, we have done with the second part of our presentation today. Now let's proceed to the third one. Third one is about cavities and about abscesses. Now this X-ray, it is such an obvious abnormality, you don't really need much effort. It is very, very obvious. You can tell that there is a rounded opacity here, and where in the right middle or upper lung zones, I think it's a middle lung. Let me check. This is the first strip. Second, yeah, it's in the middle lung zone. It's a fairly large, approximately 8 into 9 centimeters. This is actually a cavity. You can see this cavity. This is a cavity wall. Not very uniform, but not very ragged, or what we call rugged. Not very abnormal, irregular. That is suggestive of malignancy. So there is actually a cyst or an abscess which is filled with fluid. This one is fluid. This very sharp border is the upper level of the fluid. This fluid could be pus, could be blood, could be some other thing, some fluid, but you can differentiate between fluid and air. So this is air fluid demarcation, very, very characteristic of lung abscess or cavity. Presence of fluid in a cavity usually indicates active disease. Now, why it isn't full with blood or pus? Because it is being drained. This half air, half fluid indicates that this cavity is already draining into the bronchus. This person must be having a lot of expectoration in the form of purulent sputum or blood or something like that. It must be getting drained. That is why it is half empty. Differential diagnosis would include tuberculosis, lung abscess, occasionally malignancy also. There are other cysts also, hydrated cysts and other cysts, but this one looks like, I think to me, it looks like a draining lung abscess. This is two X-rays. This one, there is a big opacity, even bigger than what we saw in the last X-ray. There's a bigger opacity, but it is almost completely empty. There may be a little bit of fluid here, but mostly it is empty. It has completely drained out. Rest of the lungs also show increased lung markings, maybe some inflammation or maybe some chronic lung disease, maybe tuberculosis. In this patient, again, there is opacity. This is the right side, this is the left side, a similar, slightly smaller but completely empty. In this X-ray, again, this may be infiltration due to some infection. This again may be inflammation. So I think both these X-rays are very consistent, I would say, at least suggestive or consistent with the diagnosis of tuberculosis. In our country, tuberculosis is still common, so we see patients with these kind of cavities. Now this is more typical of tuberculosis. There's a big cavity here, but this is surrounded by an opacity which is occupying the left upper lobe. A fibrotic process, inflammatory process or consolidation with a cavity inside in the apex is very suggestive of tuberculosis. Definitive diagnosis would require sputum for AFB, but if the patient has long-term fever and weight loss, I think this X-ray could be taken as diagnostic of tuberculosis, given in the proper context. Again, similar to the previous one, there are bilateral opacities, diffuse infiltrates with some cavities inside. I'm not sure, this appears to be a big cavity here, this one. Multiple small cavities, but you have very extensive bilateral infiltrates. So if you have apical infiltrates with cavities inside, very suggestive of tuberculosis. Now incidentally, this is actually very nice air bronchogram. You see the trachea, you see the bifurcation, you see left main bronchus, the right main bronchus. Since these are actually bilateral consolidations, so you see the air bronchogram here. This is the stomach bubble. So in the proper context, this X-ray would suggest the diagnosis of very advanced pulmonary tuberculosis. Now, this is slightly different. Now, this is a big solid opacity. There is a big, almost cannonball size, big opacity, which is mostly solid, but there is a cavity inside. This cavity is eccentric, and the wall of the cavity is also fairly thick. So if you have a mostly solid opacity with cavity which is eccentric with wall which is thick or irregular, this may be suggestive of malignancy. Theoretically, you could also say that this is an abscess which has just started draining, but to me this looks more like a malignancy. Of course, it would depend on the clinical scenario. You might need sputum cytology, sputum for AFB, CT scan, or bronchoalveolar lavage for the proper diagnosis, but the first look is very suggestive of malignancy, particularly if this patient is a smoker and the patient has clubbing. I would consider malignancy as most likely diagnosis. Now you can't tell which part of the lung is this. Is it the anterior part or the middle part or the lateral part until you see the lateral film. Now if you see the lateral film, now we know that this is in the posterior part. This is an opacity corresponding to this one, and there is a cavity again corresponding to this one. So this is actually a rounded mass with secondary cavitation, very suggestive of lung cancer. There are some other features of lung cancer. If you have lung cancer, I think I'm going to cover it in a separate lecture. But presence of calcification is a point against lung cancer. If there is erosion of neighboring ribs, a fracture of ribs, or infiltration of this tumor into ribs, that will be very suggestive of malignancy. In this case, I don't see any of those things, but it does look like a malignant process. There are some other causes of cavities, and this one has got a label here. I just typed it here. And there is a big cavity, thin walled cavity. This is the cavity, but there is another opacity within this cavity, and this is also like oval shaped, and this is soft tissue opacity, well circumscribed within the cavity, and it is in the lower part, like physically dependent part, the gravitationally dependent part. So this must be a freely lying Aspergilloma. Aspergilloma is a ball of fungus which grows in pre-existing cavities, and the cavity could be due to anything. Mostly these cavities are due to tuberculosis, but this is Aspergilloma. These patients, they have actually a severe bronchospasm because Aspergillus acts as an allergen, and patient has bronchospasm. It would not be, mostly these Aspergillomas are not infiltrating into the tissues. So this is different than another condition called Aspergillosis. Aspergillosis is diffuse involvement of lung due to Aspergilloma. That is much more serious condition. Now this is a tomogram, and this is not actually a CT scan, this is a tomogram, and in this you can see this cavity and a big ball inside. This is different than this one. This is different patient, this is different patient, so this is bigger. And if you do the CT scan, you can see that there is a cavity, and inside there is a non-homogeneous round opacity, which may be Aspergilloma. Of course, in any opacity, X-ray only shows you the shadows. X-ray doesn't show you the actual pathologies, and you have to draw inferences from the appearance of the opacity, the secondary effects, and I think ultimately correlating these opacities with clinical condition gives you better diagnosis. And many times you need to do further tests also. Now we have seen some cavities, some abscesses. Now let's sum up the radiological signs. Causes first, causes of cavity in the lung. Tuberculosis, in my opinion, in our part of the country, tuberculosis remains the commonest cause of cavity. Usually it is apical and surrounded by fibrosis. It could be in the middle lobe, the lower part also, but if you have apical cavity which is surrounded by fibrous tissue, it is highly suggestive of tuberculosis, because tuberculosis typically affects the upper lobe. Abscesses, usually in the lower lobe or the middle lobe, and usually a complication of pneumonia. History will guide you to this possibility, and other lab tests like leukocytosis and fever, they would also suggest. But abscess is more likely to be a cavity filled with fluid and not surrounded by much of fibrosis. It may be surrounded by some inflammatory infiltrates, but not big fibrous tissue, because pneumonia is acute condition. Malignancy, it may be present anywhere. The cavity may be irregular wall. The wall may be irregular and thick, and in that solid opacity, there may be eccentric cavity that would be suggestive of malignancy. If this opacity is eroding neighboring ribs, that will be very, very suggestive of malignancy. Sputum for A, B, and cytology, that is very important because, as I said, X-rays only show the opacity. There may be very high index of suspicion of tuberculosis, and this X-ray may be diagnosed, but the definitive diagnosis of tuberculosis would require sputum for AB, and definitive diagnosis of malignancy would require sputum for cytology or maybe bronchoscopy and biopsy. So that was all. This is Professor Aziz-ur-Rehman, and from Medurstand we covered consolidation, collapse, and cavities in this module, and I'm going to continue with some other conditions. My emphasis would be the radiology for internists, the common condition, the common presentations, what I believe every physician need to know. Of course, better opinion will be available from radiologists because they have more experience in this field, and rare condition they will also be able to diagnose better. But common condition, I think physician need to understand. Best diagnosis will be if a physician and the radiologist, they work together, and that is perhaps the best way to come up with the perfect diagnosis. Thank you again. This has been Professor Aziz-ur-Rehman from Medurstand. Thank you.